have another transporter which change sodium to potassium. This is all information which we need to know. Yes? Drugs which will increase work of these cells are cardiotonic drugs. Yes? What kinds of cardiotonic drugs do you know? Two main groups.
Glycoside.
Yes, cardioglycosides and non-cardioglycosides. And non-cardioglycosides, they are divided into three subgroups. What? One, beta agonists and calcium. Okay. So you name first inhibitors of phosphodiesterase. Let's remember what do phosphodiesterase it break. Yes, they destroy cyclic AMP. So if we will inhibit, we will increase cyclic AMP and increase the phosphodiesterase. First group, beta-1 adrenergic drugs. Yes, the first group will attack on beta-1 receptors. What drug do you remember from the first semester?
Dobutamine.
Dobutamine, Mesomos. Can you explain what we'll do at dobutamine?
So dobutamine will help to irritate this beta-1. So
Receptor.
it inhibits beta-1 receptor, so this thing will not happen again.
It will activate JS protein. JS protein
Activates adenylyl cyclase and then CMP and then protein kinase, which activates for intake of calcium into the cell and then outflow of calcium from
and
the blood bind to troponin and then contraction will happen.
These drugs increase the inotropic effect. Yes, positive inotropic effect. What about heart rate and heavy node conductivity? Why decrease?
Increasing.
Beta-1 receptor.
Increase heart rate.
Do you remember that who is responsible for our heart rate? It is atriums and sina atria and atrioventricular node. Yes? First of all, in atriums, sodium will go into the cell and then calcium. If we will increase calcium in the cell, it will make faster, yes, this action potential. So it will increase the heart rate, increase AV node conductivity, and what about automatism? Also increase. Is it good for heart to walk very fast?
No.
No. So in acute situation we can use, but not for a long time. Because it increases the amount of oxygen, yes, and it may lead to ischemia. But if patient die, we need to use. Another drug which belongs to beta-adrenergic drug, dopamine. Do you remember something about dopamine from the first semester? Do you remember about small doses of dopamine, medium doses, and large doses? Often your composition has this information. Fine, it is beta-adrenergic drugs.
Medium drug is given for
Small doses, 2 micrograms per kilogram per minute, we use to effect on what receptors? Dopamine receptors. Yes. How many dopamine receptors are there? 1 and 2. 2. They are one where they have in vessels, in main localization vessels of the internal organs and kidney. Yes. What dopamine? No, not blockers. Adrenergic drugs. Small doses will relax vessels, effects on dopamine receptors and relax vessels. When we can use this?
to increase
To increase diuresis. Increased relaxed vessels in the kidney increase filtration and thus increase diuresis. Or sometimes we need operation or surgical operation, yes, on the internal organs, intestine maybe. And we need to decrease the bleeding. We will decrease the blood pressure in the vessels, yes, and make surgical operation. Medium doses, it will be 2-5 micrograms per milligram per milliliter. Will affect on what receptor? Beta receptor. And the same effect, yes? Also, we have beta 1 receptor not only in the heart part, it will in the just and it will increase the blood pressure. And large doses will affect alpha receptors. Where you have alpha receptors? In smooth bones. If you will escape, vessels will make vasoconstriction and increase blood pressure. Remember? Yes. Okay. It is about dopamine. First group, dobutamine and dopamine. Yes? Second group, we say that we need to inhibit phosphodiesterase to increase the concentration of cyclic AMP because phosphodiesterase destroys cyclic AMP. Yes? The second group will inhibit. Name the drug. Ambrinon. And you need to answer the same effects. Yes? It is in the heart. But what about vessels? What make constriction in the vessels? Do you remember? Calcium bind with imodulator. This complex activates what? Light-myosin kinase and light-myosin kinase phosphorylate light-myosin chains and then combine with actin. This is the constriction of the smooth muscles. Yes? If you have a lot of cyclic AMP in vessels, they activate protein kinase, which will inhibit light myosin. Oh yes. So vessels will have dilation and blood pressure will decrease. Preload will decrease. Postload will decrease. Is it good for the heart? Yes. If you have resistance, it is very difficult to pump, yes? But if vessels will be relaxed and we don't have blood pressure very high, it will be very easy to heart to pump the blood. Understand? So if we decrease preload and postload, we facilitate the work of the heart. Also, vessels in the heart can make dilation and increase the oxygenation of the heart.
Doctor, can you repeat about the calcium carbonate?
In smooth muscles and in the vessels it is smooth muscles, calcium come into the cell and bind with calmodulin. This complex activates light-myosin chain kinase. Light-myosin chain kinase phosphorylate light-myosin chains and then they can bind with actin. It is the constriction. But if we speak about cyclic AMP in this smooth muscles, cyclic AMP will activate protein kinase and protein kinase will inhibit light-myosin chain kinase. Do you remember about beta-2 receptors in vessels? Remember? Beta-2 receptors, they activate also adenylyl cell class, make a lot of cyclic AMP and relax vessels. Remember this information? Epinephrine effect on beta-2 receptors and what vessels we speak about? Brain, heart, lungs and skeletal muscles. Remember? This is it. And last group of the drugs will affect on troponin C and make sensitization of this troponin C to calcium. And calcium will better bind with troponin C. Will it affect on the heart rate? How do you think? No, because conductive system don't have troponin C. It is good for us. Yes, if patient has some problems with arrhythmia, we can use this drug because it will not affect on the conductive. I will give you some pictures later. Okay? In our country we don't have this drug. Name the drug. Levocetirizine. Is it clear? It is the first group. The second group, it is, Matthew, what group? What? Cardiac glycoside. What's the mechanism of action? Matthew, of cardiac glycoside. Sarkar.
So the drug is dioxin. They block the sodium potassium ATPase pump, which leads to accumulation of sodium inside, which will prevent the working of sodium calcium pump, leading to the accumulation of calcium inside and leading to the increased contraction.
That's not really receptor action.
Not receptor, it is the pump. Yes, no, transporter, yes, transporter. ATPase. So, sodium potassium ATPase will be blocked and sodium will not go out of the cell, will accumulate in this cell. Yes? If you have a lot of sodium in the cell, can sodium come into the cell? No, it will block this pump. Yes? Sodium, calcium, transporter. Calcium will not go out. It will accumulate in the cell. During systole, it will go to bind with troponin. During diastole, it will go into the endoplasmatic reticulum. Every contraction, it will go into the endoplasmatic reticulum. So, if we will stop using these drugs, we will have a lot of calcium synthesis, and it is prolong the time of acting of these drugs. Understand? Stop using my drugs because we have a lot of calcium in the endoplasmatic reticulum. But it may lead to side effects. Yes. If we increase the force of contractility, a lot of blood will go in the main vessel. What main vessel? Aorta. Yes. What we have in our baroreceptors. And signal will go from baroreceptors into the our brain. Yes. What we have in our brain? Solitary tract. Yes. Remember. What does solitary tract? It irritates inhibitory neurons, which inhibit what? Remember clonidine. Inhibit vasomotor center. Vasomotor center blocks the constriction of vessels and blocks work of the heart. Yes? Also, baroreceptors give signal to what nerve? Vagus. Vagus, okay. They irritate the center of nervous vagus, which release what mediator? Acetylcholine. And what have acetylcholine receptors? Yes, what receptors? M2. M2, good, M2. In ventriculus or in atriums? Atriums. What you have in atriums? Synapse. Atrium and atrioventricular nodes. Yes? Vagus, it is parasympathetic. It will decrease the work of synapse and atrioventricular node. You understand? So, a lot of blood into the aorta, chemoreceptors, signal into the brain, irritate center of nervus vagus. It releases acetylcholine. Acetylcholine affects on the M2 receptors in the atriums and decrease the work of synatrial and atrioventricular node. It may lead to bradycardia and AV block even, yes? And also irritate solitary tract, which activate inhibitory neurons inhibit vasomotor center. Remember? what we will have is automatism in atriums and in ventricles. In atriums, we will decrease automatism because of effect of pulse. But what about ventricles? We have a lot of calcium in ventricles. Yes?
Increase.
So automatism in ventricles will increase and it may lead to extrasystole ventricular and extrasystole. Understand? It increase and this will be decreased. Repeat. Yeah. Cardioglycosides inhibit sodium-potassium transporter. Sodium accumulates in the cell and block sodium-calcium transporter. Yes, and calcium will be accumulated in the cell. In systole, it will bind with troponin C and may increase the force of contraction. But in diastole, it can't go out. It will go into the endoplasmatic reticulum. The force of contraction rise and the cardiac output rise and irritate baroreceptors in the aorta. Signal will go into the brain, into the solitary tract, which inhibit or irritate inhibitory neurons, and they will inhibit vasomotor center. Vasomotor center have effect on the vessels and on the heart. And also, baroreflex will go into the nervus vagus, irritate center of nervus vagus. Nervus vagus will release acetylcholine. Acetylcholine will affect on M2 receptors in the heart, in the atriums, and decrease the work of sinoatrium and ventricular node. Also, the automatism of atriums will be decreased. But in atrium or ventricles, we have a lot of calcium, yes? And we have a lot of calcium, it will increase the automatism of ventricles and may lead to extrasystole. Why we need to know this information? On exam and control you have question, systolic and diastolic function of digoxin. Systolic, it is to increase the force. Diastolic, during diastole, blood will be in the aorta, yes, and ventricle will have diastolic phase, yes, and the gas will go and decrease the heart rate, remote conductivity, and automatism of atriums. Yeah. What about side effects? The same. They can affect also on the brain. Yes, we say that effect on the brain. Sedation, maybe some sedation, but usually it is not good blood vision. Blood vision, it is not good vision, yes. Maybe irritating or vomiting symptom, nausea, some gastrointestinal disorders.
Visual.
Yes, visual disorders. Yes, visual disorders. Why we need to know this? Because cardioglycosides have very narrow therapeutic window. Do you remember what is it? It is the window how many doses we can, how much more we can increase the dose. Yes, a narrow therapeutic window that means that we can't overdose because it will lead to toxic effect. Yes. And if patient says that he have some not good vision, or vomiting, or extrasystolia, or maybe bradycardia, we need to stop using this drug and to treat intoxication. To prevent intoxication, we have such definition like digitalization. Digitalization means that we rise dose during some period of time. Then we use the same dose every day. So first of all, we need to make a lot of dose, yes, loading dose, and then we look at the patient, make electrocardiography and individual dose. Clear? I'll give you some pictures. control will be such groups and activate ATPase. 1, 2 antibodies to the digoxin, and they are digitin.